Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. In this episode, Dr. LaRon Nelson presents a case-based discussion on the role that you, as the healthcare professional, may be playing in your patient's PrEP persistence and strategies you can implement to modify your approach to encourage persistence. Dr. Nelson is a nurse practitioner and Independence Foundation professor in the School of Nursing at Yale University. For the full online educational program, Staying on Track, Strategies to Support PrEP Persistence and Reengagement, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Nelson has to say.
So we'll start off this talk with a case. This is a case of a Black man who's 32 years old. His sexual history includes having intercourse with other men, but maybe not exclusively with other men. He has been on FTC TDF daily for PrEP for about 2 years now, but this person frequently misses follow-up appointments. The HIV test was conducted. It was not reactive. The antigen test did not detect any HIV, also negative for hepatitis B, C, syphilis, and STIs. So if we look at the data from the Kaiser Permanente cohort, it actually outlines the PrEP continuum of care within that cohort. It included about 14,000 people, 13,906 to be exact, and they were followed for the years 2012 to 2019. This cohort was mostly male, 95%, mostly white, about half were white, a little less than a quarter Hispanic, 15% Asian, and then the smallest percentage of those were Black patients in the cohort. Blacks, compared to whites in the cohort, were significantly less likely to be prescribed PrEP at all. They were less likely to start PrEP, and more relevant to this talk today, they were more likely to discontinue PrEP. So we really have to think seriously about what can be done to improve PrEP persistence. Now, the question that I would ask us all to consider is it something about our approach in the clinic that contributes to this loss to follow-up or this disparity in PrEP discontinuation that we see, and particularly among Black folks in the example that we just used? So we know that among racially and sexually minoritized people, that stigma is a barrier to PrEP persistence. And stigma, in many ways, is, if we think about it, it's sort of negative encounter that people might have in their daily life. It could be unintentionally so, but nonetheless, negative encounters that could also happen when people are interacting with us in the clinical context. So in that sense, PrEP persistence may be less about what the client feels about the drug itself, and more about the client's reacting to the environment where the drug is being prescribed or discussed. In one survey of 855 Black individuals based in the US, 53% actually reported high levels of racism and discrimination in their healthcare experiences. Very common based on this particular study. So healthcare providers need to reflect on the fact that it could be us, could be you as a provider, and our approach that could be a barrier to PrEP persistence. If clients are perceiving that their interaction with us are stigmatizing, or that they're experiencing some form of racism in their interactions with us or others in the clinical environment. So the question that we consider today is, how can we change the approach, our approach, and overcome it to create an environment where people want to be engaged? They want to hear about PrEP, they want to be prescribed PrEP, and they want to stay on PrEP, they want to persist. So here are some examples of healthcare provider implicit bias regarding PrEP. These were some really important studies that were done by Sarah Calabrese and her team, and one by, I believe, Hall. So one was focused on racism, and a study that used 100 medical students. They gave them a case about a man who has sex with men, much like the case that I discussed today, and this person was seeking PrEP. But they also presented a case, an exact case. The only thing they varied was the race of the patient. And then the medical students actually rated the Black patient compared to the white patient that was more likely to engage in risk behaviors as a compensation for PrEP. So the medical students, when presented with exact same case, the only difference was race, had negative evaluation of what they thought the patient's response would be to taking PrEP. And another study of prescribers, which was 160 of them, that were given case vignettes about women who were eligible for PrEP, there was a significant interaction between the patient's race and the prescriber's racism score on their expectations of PrEP adherence, meaning the prescribers had an expectation that based on race that it would affect person's adherence, which in both these cases might influence how you're talking to the patient, how you approach the patient, how you handle or deal with patients' expectations or requests about information, or whether they want to be on PrEP or how long they want to be on PrEP or addressing their challenges. If we already think that the patient's going to behave in a way that we don't agree with because of it, or we already believe based on the patient's race that they're not going to adhere optimally, then that does affect the patient encounter and they will be able to detect that. And that might undermine their willingness to try to persist on PrEP when the prescribers are already communicating either overtly or implicitly to them some negative evaluation of the patient. This also shows up in sexual prejudice. So another case, a medical student that was given the case of a man who had sex with men who was seeking PrEP, but those in that case who expressed greater heterosexism more strongly anticipated increased risk behaviors of those men who have sex with men and anticipated also that they'd have more problems with PrEP adherence. And then lastly, another example of sexual prejudice is for U.S. primary care providers and HIV care providers, sexual prejudice was negatively associated with anticipated adherence among men who have sex with men who are seeking PrEP. So I'm going through all these examples to say how we feel about the patient has an impact on what the patient will do long term and how they will respond to our approaches and our recommendations for PrEP adherence and persistence. So there is also an impact of implicit bias on persistence. I'll sort of just say this again. Even if you succeed in prescribing PrEP, if the person feels that you have doubted them, doubted that they can handle using PrEP, or that they're not going to want to persist in their PrEP care, that conveyance of doubt in the patient's ability will undermine their motivation to take and persist on PrEP. And this sort of provider-induced behavior, I say provider-induced because the doubting elicits a response in the patient that actually diminishes their motivation. So as providers induce this behavior, it also affirms the stereotypes that we have about the patient. So if we undermine the patient's motivation so that the patient is less likely to adhere, it just confirms our suspicion that these patients won't adhere. And so what happens often is that we don't recognize that our bias is actually showing up in the patient account and actually negatively influencing the patient's behavior. This could also impact what PrEP options are offered. So, for example, on-demand PrEP or long-acting injectable options for PrEP might not be offered if the healthcare provider thinks the person is irresponsible. They just may not bring it up. It also limits the ability of the potential PrEP user to choose the option that works for them, that they might actually best persist on if they're having negative responses to providers' conveyance that they doubt them or have negative expectation of what they would do if they're prescribed PrEP. Now, this model was developed by Van Ryn and colleagues, which talks about the impact of racism on clinical cognition. And this is important because oftentimes in these clinical situations that are high stakes sometimes or high intensity, if it's a busy clinic day and you're seeing a ton of patients, that this actually depicts how racism influences one's mental model in the clinical decision-making. And so it's important to understand this because this might be happening in your setting. And this could be influencing observation that you're seeing with some of the patients. I'll just go through a few of these just to sort of illustrate it. But societal racism, the stuff that's happening outside our clinic, does have an impact on us because we don't live in our clinics. We live outside the clinics and we come inside these places to work. We bring all that stuff with us implicitly and unfortunately sometimes explicitly. So our feelings toward and expectations about patients that are associated with the patient's racial classification also has an encounter on the patient's behavior. It influences how we interpret what they tell us, whether we believe what they tell us, how much weight we give to it, how we interpret the signs and symptoms, and it also influences our diagnostic steps. Importantly, it influences our recommendations for treatment, whether that is prescription of PrEP at all, whether that is different types of PrEP that we might prescribe, and what we offer to the patient to help them persist on PrEP over the long term. So if you think about this model, it offers us an opportunity to rethink what it is we think we're seeing. And so the stereotype threat, which I mentioned before, is just the behavior of the provider that induces a behavior in the patient that confirms what we thought the patient would do anyway. And so if we think about demonstrated effects of stereotype threat, which is the patient comes in, they're stressed out about something that we've said to them or done with them, so they have lower working memory capacity and cognitive performance. They're not processing what we're saying as quickly or as fully as we think they should be. The implication of that is that they have an inability to follow treatment instructions. You said all this stuff, then they've left there only hearing half of what you said or been able to process little of what you've been able to tell them, which will influence their persistence, which will confirm my stereotype that they won't adhere over the long term. They may have lower performance expectation and self-control, which translates into lower self-efficacy regarding their ability to actually adhere to treatment. If they're stressed, that creates mental exhaustion, which means they'll have lowered effort. That will show up as lowered motivation to adhere to your recommendations for adhering to PrEP. So avoidance and disengagement. So if they're stressed by you, or if they're put off by you, or if they felt stigmatized, they will avoid and disengage. And that usually looks like avoidance of this clinical setting again. They don't want to come back to the place where they want to experience that same type of negative interaction that they've had in this encounter with you. So what that means is that they don't come back. We see that as a missed visit. The patient missed the visit, but we might miss the sort of underlying driver of that, which might be a negative experience at the last clinical encounter. If they miss visits, it will obviously affect PrEP persistence because they can't get reassessed and prescribed PrEP over the long term. This is important because many of these things are things that we can control if we figure out a different approach to our patients that does not elicit these types of reactions that then diminish their interaction with the healthcare system and engagement with our recommendations. So there are ways to improve conversations about PrEP. First, I would say we want to normalize PrEP as a prevention option for anybody who is having sex or who plans to be sexually active. The ways to do this: you initiate the conversation with intention, do it in ways that are respectful. You want to build a relationship that's built on trust and has good rapport. You want to provide care that is centered on the person, not on the form. That can happen sometimes. We go by what's written here, but the person is not the form. And so you want to make sure that the care you're providing, the approach, how you're assessing them is based on who they are as an individual. And you want to provide guidance, coaching, but not controlling. This can look at asking before telling, before making a recommendation, understand what the patient knows, what the patient might want, and then offer sort of your review of where you think that might work given what you know about their situation. But ask before telling. And then think about this idea of tough love, this thing that I was trained in, and I know others have been, which is about you gotta, in some ways, take the gloves off, scare them. Tough love can work immediately to scare somebody into taking PrEP now. They'll take the prescription or they'll take the bottle and they might even go home and they'll take it for a few days. But that actually undermines their psychological well-being. It creates stress. It creates fear. And that is not sustainable over the long term. The patient will avoid feeling that stress and that psychological distress. And to avoid that, they'll avoid you and they'll avoid the clinic and then they'll avoid PrEP. And so while it might succeed in sort of short-term PrEP use, it definitely undermines any goals for long-term persistence. You want to avoid language that is stigmatizing. If you can set up safe clinic spaces, that is very helpful, especially those that promote representation of diversity in different aspects: racial, ethnic, gender, and sexual diversity among people who might visit your clinic. Think about integrating sexual health and harm reduction into your practice. Every human is different, And I think having your patients understand options and ways to exercise those options that are more consistent with how they live their lives is also helpful. It is affirming to the patients about how they decide to live their lives. And they have other strengths and values that you also want to be sure to affirm. And then lastly, you have to believe in the client, believe that they can do it, and let them know that you believe that they can accomplish these goals, that they can persist on PrEP over time, and that you're there to help and work with them to find ways to support their persistence over time. There's an example I'll share with you of providing person-centered care to engage in PrEP persistence. This model is called a C4, which is short for client-centered care coordination. It's a model I was involved in developing to address PrEP initiation and adherence, specifically in the HIV Prevention Trials Network 073 trial that was done in 3 cities, and it was focused on daily oral FTC TDF PrEP initiation and adherence for Black MSM. We followed them over a year, 52 weeks. But this model is grounded in self-determination theory, which is theory from social psychology about what is necessary to support human motivation. And it mostly says that human behavior is influenced by these concepts that happen in social settings. But it also considers that the healthcare is a particular type of social setting that also will influence human behavior. It isolates in some ways social psychology, which we apply to the larger world, and say the healthcare setting, like an educational setting or a workplace, is a social setting, and what happens there will influence the behavior of the people in that environment. This includes the patients. C4 also uses a lens called integrative anti-racism lens, which considers the way that racism intersects with other intersectional identities that are marginalized in social settings. So here's some examples of how we operationalize these components of self-determination theory. There are 3 components: autonomy, which is the need for humans to feel free, not controlled. The second one is competence, which is the need to feel that you can master a particular goal, that you can accomplish it, you have what's needed to do that. And then the third is relatedness, which is the need to feel authentically cared for by somebody who's important to you. And believe it or not, in the healthcare encounter, you are an important person to your patient, and they do need to feel that you have some authentic care about what happens to them. So, and one component of C4 includes behavioral counseling. These are just some ways that you can demonstrate autonomy as you sort of counsel patients about PrEP and persistence. So one is the client gets to decide what they want to address. The client should identify impediments to their goals. You can help them with that, but it really should be the client telling you what is the barrier, not you dictating to the client what you think is the barrier. The client is also encouraged to self-identify solutions because they'll identify solutions that make sense for their lives. We identify solutions that make sense for how we live our life and the resources available to us, which is not always the same as our patients. And then the client should be informed that they are free to reject any solution that we propose because we don't have any control over this situation. We support their right to choose what's best for their life. For competence, for example, we should express belief that the client can accomplish the agreed upon goal and then collaborate with them to assess whether or not this is reasonable. Given what the client has told us about their life, given what you know about the medication and what it requires to persist on it over time. So you can support the client's aspiration, but also you want to encourage feasibility because you want the client to be successful. And then relatedness, one way to express this is to inform the client that you respect whatever decision that they make and that you'll be supportive in an ongoing process to help them maintain or improve the quality of their life. And as we think also about integrative anti-racism, consider, for example, if the client is resistant to you, and it might not make sense. Why are they pushing back so hard on what I'm offering? That it could be a response to the history of anti-Black or homophobic experiences that they've had in healthcare systems, or from people that they've had to rely on for help, like the healthcare provider. And then let's go on to another component of C4, which is action planning. So again, we'll just take you through quickly these various components that address autonomy, competence, and relatedness. So a way to express autonomy in action planning is to ensure that the client is fully aware of all their options so that they can make fully informed decisions about their action plan. that the client is encouraged to self-identify action steps, and that they know that the final decision maker on their plan and on how to prioritize those steps belongs to them. It's not our final decision. For competence, we want to assist the client in identifying strategies that they can use to implement those action steps, and then assist them in problem-solving ways to overcome barriers that we can anticipate now or that they might encounter along the way. Relatedness, again, which is showing that you care authentically. You want to express respect for the client's action plan, reassure them that your role is to support their plan, not evaluate their performance, and inform the client that you have developed a plan, not a contract, and that you want to continue meeting regarding the outcome of this plan, and that that's a plan that can be revised. They're not wed to it. There's no penalty from you if they aren't able to follow the plan as outlined during that clinical visit. And then again, for integrative anti-racism, just think that imposing any component of the plan against the client's wishes can be a reflection of heterosexist or white supremacist logics that allow us to justify why we can overpower the client's decision with our own decision. So let's revisit this case study. So again, Black man, 32 years old, comes in with a sexual history of that includes intercourse with men, has been on daily oral PrEP for about 2 years, misses a lot of appointments. So what do we do with this case? So in this situation, you have to address the issue head on, the issue that is going to undermine this persistence, which is that they're missing visits. So we inform them. I inform the client that you've missed visits and that these visits will lead to gaps in prophylaxis. So saying this is not to put the client on the spot. It's to support the client's autonomy, to make sure they can understand the link between missing visits, not being able to get a PrEP refill, and not being able to persist on PrEP, which will undermine their own HIV prevention goals. So being clear about why you're saying it, not to be punitive, it's to say, we want to make sure you understand exactly what happens when you miss these visits and how it impacts the goals that you've set for yourself. But then also ask, so tell me what makes it difficult for you to show up on the times that you've agreed to in the scheduling. So in doing this, then the client sort of says, revealed to me, well, they feel like when they come to me, I emphasize or overemphasize they should never miss a dose. And that I made it seem that Black men are at fault for HIV in Black communities. Because, if I say, in order to stop the spread of the epidemic in the community, and most of the epidemic, the new cases are from men who have sex with men, that we really need you to be on PrEP. So the patient is interpreting that as me saying that Black men are at fault for HIV in Black communities and that they can never miss a dose. And so that if that happens, the client says, if I miss a dose or I miss a visit, I feel ashamed and that it's hard for me to then come back and face you. So then my response in this case was, well, I didn't mean to pressure you. It was not my intent. And my support is not contingent on how often you take PrEP. Those are your decisions. What I want to do is partner with you to help you reach your prevention goals. So that is expressing relatedness. I care. I was doing this because I was trying to be supportive, not to try to pressure you or judge you. Also, I would say that there are options that have worked for other patients that have helped them stay on PrEP. And I let the client know that I'm happy to discuss some of these options with you. Again, this is supporting their autonomy so that they're fully informed and they can make the choice that's best for them, but they have to know all the options. Then also, I let the patient know that we can identify actions that you, the patient, thinks can help you stay on PrEP. And we can consider it an experiment. It's a plan, it's not a contract. So we can decide on some actions, you can try them out, we can see what works, and then we'll tweak them as needed at the next visit. Key take-home points here. PrEP persistence is influenced by factors that are inside the patient, which we're probably all familiar with, but also factors that are outside the patient, and that the healthcare climate and the behavior of the clinician are influencing factors on PrEP persistence. There are tools available to help clinicians more accurately interpret patients' behaviors. One of those I presented to you was Van Ryn's model of racism, implicit bias, and stereotype threat. Is worth a read. Fear and control are unsustainable sources of motivation. We use them. We've all used them before. Some people have used them on us, and they can work in the immediate term to scare people into doing something, but they have consequences. They're unsustainable because people will not come back again to be scared and controlled. They will avoid them. It will run out. And when we do that, patients who feel forced or controlled will resent you if and when they fail on whatever that plan was. They weren't ready for PrEP, or if they wanted to take a pause, or if they didn't want to try some of these strategies that you forced on them. If it doesn't work out for them, they will be upset with you because this would have been your plan, not their plan. The patients who feel judged or shamed, like the case I presented to you, will avoid returning to clinic because they don't want to have that judgment or shame. They don't want to experience that. So then this fear and control sacrifices long-term persistence for short-term usage, and we really need patients to persist over the long term. So these strategies that I discussed today are approaches that help build sustainable motivation and skills building. They actually aren't isolated to patients who are on PrEP. You can use these for all your patients in your practice, no matter what health condition that they're there to see you for. That's what makes it sustainable. You can always be using them. And there are approaches that actually support the patient to be energized and motivated and not feel stigmatized.
Thank you very much to LaRon Nelson, and thank you to our listeners for joining in. To get more from our program, see the link in the show notes. You can view a foundational video module on PrEP persistence, more vlogs featuring specific case examples, clinical thought commentaries from people using PrEP, and downloadable PDF resources for healthcare professionals to print and share. To automatically get new episodes as soon as they launch, subscribe to the CCO Infectious Disease Podcast. Thank you and have a great day.